increase significantly. And what were those receptors that we tap into when we have low oxygen levels? Yeah, the peripheral chemoreceptors. Absolutely. And then with the alveolar collapse, we now start to have a decrease in compliance. So it takes more effort to try to open up those alveoli and those respiratory units. So in order to compensate for the really bad compliance, you'll have an increase in respiratory rate. You have the deflation receptors that are going off. You have the irritant receptors that are sending signals, hey, breathe faster. I don't like what's going on down here. The J receptors that are signaling, hey, there's some pain, there's some anxiety that's happening. Again, all of these things are going to increase that patient's respiratory rate. The physiologic response to hypoxemia, increased respiratory rate, increased heart rate. The blood pressure is going to be decreasing, like we talked about, decreasing with the compression of the mediastinum and the decrease in the venous return. You're going to have cyanosis, especially if the hypoxemia gets bad enough. You'll start to see bluing or a purplish color around the lips. If you can't tell by the color of their lips, look at the gums. Look at their tongue. Is their cheek, the inside part of their cheek, is that still pink? If it's not, then we have some cyanosis going on. Now, when we start looking at our IPPA, what's our expansion going to be? Well, we're going to have unilateral or unequal chest expansion. You have the affected side that's not going to move. Let's say it's the affected side's over here. So this side, your good lung, will continue to expand. Your bad lung will not move at all. So you have a difference or unequal chest rise. What are my percussion notes going to sound like? Yeah, they're going to be hyper-resonant. So you'll have hyper-resonant breath sounds. How well will your stethoscope be able to hear between all of this air that's here and what's going on right in the lungs? Will you be able to hear everything as well as you could on this side? Absolutely not. So this side you will see diminished. If that pneumothorax is so bad, they could even be absent on this side compared to the good lung. Now, what happens when we have all of this air that's occupying space? Look, you start to see everything shift. You have your heart shifted over. You have this left lung that's starting to collapse a little bit. What's going on to the trachea? Yeah, you start to get a tracheal shift away from the affected side. A student of mine a couple of years ago told me, pneumo kind of sounds like Nemo, and I'm going to remember that Nemo swam away. So pneumothorax, remember that the trachea will deviate away from the affected side. Again, this is space occupying air in the pleural space, pushing everything to the unaffected side. And then if I were to listen to my heart sounds, are they going to be in my normal spot? No, everything is shifted. Everything is shifted. Again, occupying space, moving everything over. Whenever I look at my pulmonary function test, remember this is a restrictive disease. So all of my volumes and my capacities will be decreased and my flows will be relatively normal. So it is a restrictive condition. Now, in all reality, you wouldn't be doing a PFT when your patient has an acute pneumothorax. Now, could they get a pneumothorax while they're doing a PFT? Sure. But I would not be doing a PFT to identify the pneumothorax. Just food for thought. When we look at the arterial blood gases and the hemodynamics here, we have a breakdown between a small pneumothorax and a large pneumothorax. When we have small pneumothorax, we're going to have a patient that is trying to maintain their oxygenation. Whenever they try to maintain their oxygenation because that PaO2 level has dropped, what is that going to show? Well, we're going to have some level of hypoxemia. Well, what again is the physiologic response to hypoxemia? Breathe more, beat more. So my respiratory rate's going to go up and my heart rate's going to go up. When I start to have a larger pneumothorax, now I'm not going to have the ability to maintain my ventilatory status to keep up with the demand. So when I start to lose the ability to eliminate carbon dioxide and oxygenate for myself, I now start to move into acute ventilatory failure. And just to talk about it here, you have two different types of ventilatory failure. You have type 1, which is associated with hypoxemia. And you have type 2 that's associated with the ventilatory status, or the CO2. So in this case, the patient has an inability to oxygenate and an inability to ventilate. So this would be a case where you have type 1 and type 2 ventilatory failure. When we look at hemodynamics, the areas that are going to be increased is going to be your CVP, your right atrial pressure, your mean pulmonary artery pressure, your pulmonary vascular resistance, and your right ventricular stroke work index. Again, this is an issue at the lungs. Anytime that you have an issue at the lungs, everything behind it is going to increase. Everything beyond it, so the pulmonary capillary wedge pressure, is measuring the left side of the heart. That is beyond the lungs. All of these will be either normal or decreased. Your pulmonary capillary wedge pressure, cardiac output, stroke volume index, cardiac index, systemic vascular resistance, and the left ventricular stroke work index will all be different from the right side of the heart here. So this is measuring everything on the left. This is measuring everything on the right. Increased, decreased, or normal. Imaging. So anytime that you see a distinct line like this, a distinct line in your chest x-ray, I want you to see if the pulmonary vascular markings reach the chest wall on the lateral side. If it does not, be very suspicious of a pneumothorax. This right here is a quite large pneumothorax. So ideally what we want to do is we want to take this image with the patient in an upright position. When we get them in an upright position, what that will do is it'll try to isolate the air to the top. So just like when we have an air bubble in our ABG syringe, the air bubble is going to go to the top of the syringe. Same thing here is when there is air in the pleural space, it's going to navigate to the apex of the lungs. If there was fluid, if this was blood in the pleural space, all of that fluid would be down here in the base of the pleural space. So ideally, we want to get this image in an upright position. We're going to see an increase in translucency, which is darker lung fields. So you see the darkness here, and you have pulmonary vascular markings that do not go all the way to the rib borders. So this increase in translucency right here is showing you that there is air. Anytime that you have big shades of black in your lungs like this, it's not always a great sign. So you'll see a tracheal shift and a mediastinal shift away from the affected side. And on the affected side, you'll start to see the diaphragm being depressed. So here, you can start to see that there is a widening of the diaphragm here. If this goes untreated, we could see this diaphragm move all the way even low outside of the image. When you have a deep or a depressing diaphragm like this, what we call that is a deep sulcus sign. Deep sulcus, S-U-L-C-U-S, deep sulcus sign. That is an indicator and a telltale sign for a pneumothorax. So go ahead and write deep sulcus sign and put a big old star and circle around that, because you will see that in your future. Other things that you'll see is you'll see alveolar or lung collapse and atelectasis. You push this over far enough, hard enough, you'll start to see the left side collapse as well. So we want to make sure that this patient gets treated pretty quickly. If you are in a situation to where X-ray is going to take a little bit. You've got a patient that came in from a car accident, and it was a 5-car accident that's bringing in 15 to 18 to 20 patients all at once. Radiology may get overwhelmed a little bit. They might. Not every department is equipped to bring in or to take on that many patients all at once. One skill set that I would encourage you to start learning about this is point of care ultrasound, doing what's called lung scanning. There is a blue protocol that is out there that shows you exactly how to do point of care ultrasound when it comes to lung ultrasound. This is as accessible as you want it to be. You can get an ultrasound that sits in your pocket and it connects to your phone. You can have an ultrasound that is in an accessible area like an EKG machine. It is a skill set, just like learning how to use a stethoscope is a skill set. And all respiratory therapists, all clinicians really, should learn how to use point of care ultrasound. And one of the things that the MBRC likes to ask, and there's a question that is very similar to this, but they ask, what is the exam that you use in the emergency department with trauma patients? And what we're looking for in that is a FAST exam or an EFAST exam. It's a focused assessment with sonography in trauma, FAST. Focused assessment with sonography in trauma, FAST. That is one thing that we need to kind of put into our memory banks. But when we look at lung ultrasound, when we look at this, we can actually see what is going on underneath the surface of the lungs. And one of the things that we will look at is when we do our imaging lecture is we will talk about point of care ultrasound in imaging. And we can see that the visceral and the parietal pleura, they should be moving over the top of one another. But whenever I start to get air in that, I don't get to see that movement. So when I have an absence of that movement and I can't see that, we call that an absence in lung sliding. An absence in lung sliding. So if you have an absence in lung sliding, that is a sign for a pneumothorax. If I look at my lung sliding, or if I look at my lungs in what's called M mode or motion mode, and I get this look where it looks like a barcode, this is no good. This is no good. It should not look like a barcode. You should have more to the picture than what we have here. And then if I can identify exactly where I have lung sliding and where that lung sliding stops, that is where the tip or the end point of the pneumothorax is, and I can identify where we need to take care of or manage or treat that pneumothorax. So that point where you have lung sliding to stop or a cessation in lung sliding, that is what's called a lung point. So 3 different things that we can look for: an absence in lung sliding, barcode signs, or the lung point. All 3 of those are indications or signs that that patient has a pneumothorax when doing or using ultrasound. Again, that exam that we use in trauma, a FAST exam, focused assessment with sonography in trauma, FAST. All right, so now looking at management, managing pneumothorax or pneumothoraces. So depending on the size, if you have a small pneumothorax, which is classified at 15 to 20% of a pneumothorax, we don't necessarily have to do anything with that. The body will naturally reabsorb that air in about 30 days.